Hello, everyone. My name is Dwayne Peters, and I'm with the National Office of the Lupus Foundation of America in Washington, D.C. Our discussion today is about a very important research project and a research study that is sure to be of interest to people with lupus, especially young women of childbearing age. The study is called IMPACT, which stands for Improved Pregnancy in Antiphospholipid Antibody Syndrome, APS, with Certolizumab, I'm sorry, I'm probably going to mispronounce that, therapy. The data from this study could potentially help secure a potential new treatment for high-risk pregnancies. Our guest today is Dr. Jane Salmon. She is the research chair at the Hospital for Special Surgery in New York City. Dr. Salmon is the Colette Keene Research Professor at the Hospital for Special Surgery. She is Professor of Medicine and Professor of Medicine in Obstetrics and Gynecology, and also Associate Dean for Faculty Affairs at Weill Cornell College of Medicine. And I'd like to please introduce to you Dr. Jane Salmon. Dr. Salmon, thank you very much for joining us today in our program. The first question is just really about yourself and your work. Can you tell us, how did you get started in lupus research, and in particularly, what motivated you to focus your career on pregnancy and lupus?
Well, when I was training quite a long time ago, I have to admit, I saw young women with lupus. And at that time, there really wasn't a lot of interest in diseases of women, particularly young women, and particularly women of color. And lupus was a total mystery. And I was interested in research, and I'm a problem solver, so lupus became something that was challenging. And the other issue for me personally was I was a young woman just like the patients. And the difference between the patients and me was that they had a disease and I didn't. So I became really committed to understanding their disease and working to make their lives better. And why pregnancy? Because when you talk to a lupus patient, the first thing she often will ask you is, can I have a child, and will my child have lupus? So when dealing with diseases of women, reproductive health comes to the forefront. And again, it was an area that was neglected to some extent, and something that I'm passionate about. I have 2 sons and they're my life. So I want to help other people have that kind of joy.
Yeah, certainly it's been an area that is attracting a lot of interest, and I know that your work in this area has been quite important and well recognized. Can you talk a little bit about, for our audience, what are some of the challenges that people with lupus face during pregnancy? And what would be your advice to people with lupus who might be considering becoming pregnant?
There's certainly anxiety about taking medications, about transmitting the disease to your child, about your own health and whether or not your health can sustain a pregnancy. And there are fertility issues because of drugs. So the key advice I can give is, first, you need a team of doctors to take care of you, your rheumatologist and the obstetrician. And in a way, I'm giving a responsibility to you as a patient to making sure they communicate, because that isn't always flawless. It's sometimes challenged, but you need that kind of communication to help with your care. The second thing is, before you contemplate a pregnancy, talk to your rheumatologist. There's certain points in your disease, and I'll talk a little bit more about that when I talk about my study, that it's safe to become pregnant. Your disease needs to be under control. Your medicines might need to be shifted around so they're compatible with pregnancy. So every year, you and your doctor should talk about, do you want to become pregnant? When do you want to become pregnant? And what's the best strategy? And finally, women who become pregnant often have this reflex: I'm going to stop all of my medications because they'll be bad for the baby. That's really not true. Many medications are safe, And what's a bigger risk for pregnancy is having disease become very active. So don't have a reflex to stop all medicines. Talk to your doctor, see what's compatible, what's not, and try your hardest to stay on medications that will keep your disease quiescent, because that's the best thing for your pregnancy.
Yes, it's important to stay healthy during that pregnancy, and
Yes,
I think
yes.
it's very, very good advice. So I know we're going to talk a little bit about the data from your study, which focuses on women who have had a difficult becoming pregnant. What insights do you happen to have for the growing trend among women with lupus who are experiencing successful pregnancies? Do you have any advice for them?
I think if you look at reproductive health, maternal and fetal mortality overall in the United States, it's something we're not entirely proud of. On the other hand, with high risk pregnancies, we've gotten a lot better. We understand much more. I think the challenges that we face as a country have to do with access to care and the increasing prevalence of comorbidities like diabetes, like metabolic syndrome, like hypertension, and obesity. I think certainly from the standpoint of lupus, if you look over the last 20 years, maternal and fetal mortality have much improved, even more so relative to the non-lupus population. And why we've made that progress, I think it has to do with developing an understanding that disease should be quiescent and counseling women. I think it's also some of our maternal fetal medicine studies that you have when you're pregnant. We have a better understanding of who's going to get into trouble and who's not, but it's certainly not optimal. But I think the greatest challenge in pregnancy complications in lupus is we have no real treatment. The only prevention is getting pregnant when your disease is quiescent and staying on your medications. But once someone is at very high risk, and I can tell you what kinds of women are at very high risk, there's nothing we can do except worry. Watch them very closely, but there isn't an intervention yet. And that's what I'm really excited about talking about, what kinds of interventions we have. I think in the context of pregnancy complications in women with lupus, there's certainly, as you talked about, pregnancy loss. There can be early and late miscarriages. Early miscarriages before 10 weeks are very common in the general population, but multiple sequential early miscarriages are not that common. Growth restriction, that would mean that the baby isn't growing really well because the placenta isn't healthy and isn't nourishing the baby well, is a common problem in the United States, but it's more common in lupus patients than patients without lupus. Then there's a syndrome called preeclampsia. It's also called toxemia, and that's associated with high blood pressure, problems with the kidneys so that protein leaks out of the kidneys. And that's not lupus nephritis. It's another reason for protein in the urine. And patients can even develop seizures. It's a very dangerous situation, and it's a manifestation of poor placental development. So the placenta is sending toxic factors to the mother, and the mother's becoming sick, but the placenta also isn't nourishing the baby well, so those babies don't grow. And that's a very serious problem in lupus and in non-lupus, and that's one of the things that I'm most interested in developing a treatment to prevent.
Yeah, you had mentioned, or the title of the study includes APS, antiphospholipid syndrome. Can you tell us a little bit about what that is and how it impacts people with lupus, please?
So, antiphospholipid syndrome, it's APS for short. It's a lot of words, it's a lot of syllables. And it's syndrome means that it's not exactly a disease, but you have to have a few elements to qualify for having the syndrome. So the first thing is blood clots in arteries or veins. That would be a stroke or a phlebitis or a pulmonary embolus. Second element is pregnancy complications, multiple miscarriages or preeclampsia, preterm delivery because the placenta isn't growing well. And the third key element is autoantibodies. Those are proteins. Lupus patients have lots of autoantibodies. You have anti-DNA antibodies, but this is an autoantibody against a phospholipid. It's a protein on the surface, a lipid on the surface of cells. So antiphospholipid antibodies occur in about 25% of women with lupus. But the syndrome means you don't just have the antibodies, but you either have pregnancy complications or blood clots. And that's a little bit less common in lupus, having the syndrome. So many lupus patients, as I said, 25% could have the antibodies, and those are patients for whom we're worried about pregnancy complications, but they may not have had them yet. So that's what the syndrome is, either blood clots or pregnancy complications or both, and this group of autoantibodies called antiphospholipid antibodies.
Okay. Now I'm going to stumble over this word again, and I'm sure you'll be able to have it roll off your tongue. But
Certolizumab is the word.
Certolizumab. Okay. Why this certolizumab, and how did you determine that this would be a good choice for this patient population? How did you get here?
So this is going to be a story, and it's I think a really wonderful story. I had a mouse model of lupus pregnancy complications. So you could take a mouse and inject the mouse with antiphospholipid antibodies from a lupus patient. And that mouse, you do that when the mouse is pregnant. And then that mouse's pups, many of them die, or they're small, or they may even get preeclampsia-like illness. So we were able to create in the mouse exactly what patients get. So we could use this mouse as a tool to say, what is it about antiphospholipid antibodies that cause damage to the placenta? And historically, because I told you that patients with antiphospholipid antibodies have blood clots, everybody said there are blood clots in the placenta doesn't work well, we should treat these patients with blood thinners. So that's kind of what was done, and it wasn't terribly effective because they still had pregnancy complications. So what we did is thought about inflammation, because lupus patients have inflammation systemically. And is that what's driving the pregnancy complications? So we took mice and treated them with specific blockers of inflammatory pathways, or used mice that were genetically deficient in inflammatory mediators. We could rescue the pregnancies completely. We were very excited. So TNF alpha is one of the key inflammatory mediators that we found in inflamed placentas in APS treated mice. And there's some evidence that there's TNF alpha actually in amniotic fluid and placentas of women who have pregnancy complications. So we decided we were going to block TNF alpha, it's an inflammatory cytokine, in very high risk women who were pregnant. So then the question became, as you asked me earlier, lupus patients are doing much better in pregnancy. And that's absolutely true. About 20% of lupus patients whose disease is quiescent when they conceive will have a complication. So that's not a big number. And for our trial, we had to figure out who are those 20 out of 100 patients. We didn't want to give drug to patients who didn't need it. So we did a large observational study, which is called PROMISE, where we followed 500 lupus patients every month of pregnancy. And then we said, at the first trimester, what were the indicators that women wouldn't do well? Because by the end of the study, we knew who did well and who had preeclampsia and so on. So we identified specific markers, blood tests and clinical profiles that suggested a high risk of a complication. And those were the women we studied in the IMPACT trial. And we chose a TNF inhibitor because of the mouse data. But most importantly, certolizumab is the only TNF inhibitor that doesn't cross the placenta and get into the baby. So that's specifically why we picked that TNF inhibitor. All the other ones would have worked probably as well, but they would have gotten into the baby, and it's slightly immunosuppressive, so the baby could be vulnerable to infections, even though it's pretty unlikely, but we wanted to be careful. So that's the story of how we got to the study.
Okay, that's very good. Okay, so let's talk a little bit about the study and the results that you've seen. What have you seen so far in those people that you have enrolled, and are they making progress, coming to full terms and delivering healthy babies? What's
Okay,
the results?
so actually that's what I'm most excited about. So I spent 10 years studying mice and 10 years following patients to figure out who I could intervene with and make a difference in their lives and their pregnancy, or at least try to. So we're enrolling the patients at highest risk. So those are women who have lupus anticoagulant, which is a specific antiphospholipid antibody, and they have antiphospholipid syndrome, which means they've either had pregnancy problems or blood clots. And what we found from our observational study is 44% of people with these characteristics will have either preeclampsia before 34 weeks, which is not a good situation, it's pretty severe, or have evidence of placental failure and poor growth at less than 30 weeks. So these are pretty serious outcomes. So 44% of people who we are enrolling in the PROMISE study have that kind of a risk. And the way we enroll patients is you contact myself or Dr. Werebranch in Utah, but I think if anyone on this who's listening to this wants to be considered and thinks they could be, they can contact the foundation, the Lupus Foundation of America, and get some screening. But once these women contact us, we ask them questions, we get some blood work, see if they qualify for the study, and then they can potentially get into the study. So we've enrolled 25 patients, and of those 20, and most of them have had really serious pregnancy complications before. Most of them haven't had a successful pregnancy or have had preterm deliveries at 30 weeks and situations that are not ideal. So of the 25 patients we've enrolled, 23 of them have completed the study, and only 3 have had an adverse outcome. So that's 13%. So we've been able to go from 44% that we expected down to 13%. And of those patients who had preeclampsia, they had it pretty late, and all their babies are fine. So their babies are okay, but in terms of the study outcome, if you have preeclampsia, it means the study was not successful. So all of our patients have had babies who end up being healthy and are okay. But it's kind of amazing. And no one's had a complication from the drug. The drug is a TNF inhibitor, so there are risks of infection, but patients only take the drug for 20 weeks of pregnancy, from week 8 to week 28, and then we follow them. So it's kind of awesome. But again, we have 50 patients to enroll, so we're only halfway there. So all the data could change, so you can't pat yourself on the back when you're midway through a study. But we're really optimistic and really excited, and the patients in the study are very grateful. And we're grateful for them to have taken the risk and enrolled.
Yeah, this is really great news. I mean, I think, when you said from going from 44% to 13, I mean,
Yeah.
I don't know what that percentage is as far
It's
as
statistically significant, but we've
Yeah.
got to keep going.
Right. I mean, it's very encouraging news, but you have to wait until you see the whole group.
And though my passion is lupus and lupus pregnancy, ultimately, as a physician, you want to have the broadest impact you can. And lupus is an uncommon disease, and lupus pregnancy is a subset even of that. But what I think we can learn from the IMPACT study is if we can prevent preeclampsia in lupus patients where there's such a high risk in this subset, this therapy may be effective in other women who are at risk for preeclampsia. So preeclampsia occurs, it's the most important cause of morbidity and mortality in the United States in terms of pregnancy. And we have some ideas, people who've had previous severe preeclampsia are more at risk of getting it again. So the opportunity to use lupus as a window onto a more common but serious disease is also, for me, quite extraordinary.
Right, so that it could have implications beyond people with lupus,
Yes.
is what you're saying, and that's really encouraging. And you are to be congratulated, you and your team. And this is certainly very good news, and we're happy to share it with our community. Do you have any final thoughts you'd like to bring out before we close?
I think my final thought is gratitude. And it's gratitude for patients, the 500 lupus patients who were followed every month of pregnancy throughout the United States. And they had blood drawn every month, and their husbands were saying, "You're exsanguinating my poor wife, you're damaging the baby." We learned a lot from the sacrifice they made, and we didn't hurt their babies or hurt them except for a needle prick. And the women who agreed to be in the impact study, and I hope will continue, also are making a major difference both for themselves and for the community. So my gratitude is really in patients who are in trials, in foundations like the LFA that support research and promote research, and the NIH, NIAMS, which is also a major funder of all of my work through my career. So I'm grateful.
Well, congratulations, and I want to really thank you very much for taking time to speak with us today about this great study. Thank you for all the work that you've done throughout your career in this important area. For more information about the IMPACT study, please send an email to research@lupus.org and include IMPACT study in the subject line.